Hello everybody. In this section we will be talking about the antibiotic vancomycin. It's a glycopeptide. First in the class, it's a cell wall active agent. It binds the d-ALA sequence and impairs the peptidoglycan synthesis. It only works on gram-positive bacteria because it is unable to penetrate the outer layer of the gram-negative bacteria called the outer membrane protein. It has activity on anaerobes, and that is why it is useful for C. difficile infection. And it's almost 60 years now it has been in use, and in many a clinical indication, it is the antibiotic of choice when there are drug-resistant gram-positive bugs involved, and in some it is empirically used as the first up choice. If we look at the utility, the major utilities for MRSA, including serious infections. For methicillin-sensitive Staphylococcus aureus, beta-lactams are preferred because they have shown to be better than vancomycin when it comes to results. It can be used as a substitute when patients are allergic to beta-lactams. It also has activity against enterococci, although a lot of resistance is being seen. And oral vancomycin is available for C. difficile infection. It is not absorbable. It is one drug where therapeutic drug monitoring is advised when intravenous vancomycin is used, and that is both for therapeutic success and limiting toxicity. So if we want to extrapolate all the data that we have, then they are all based on this therapeutic drug monitoring. The recommended monitoring is to look at the area under the curve by the MIC ratio, and this should be somewhere between 400 to 600. And this is especially important when the MIC is more than 1 milligrams per liter. We always knew this, but we thought that if we could just check the trough level, that is the pre-dose level of vancomycin, we can extrapolate it to the AUC MIC. But now this no longer holds true. What we do is we give the vancomycin. After 1 hour of infusion or so, we check the drug levels, and then before the next dose is due, we check the drug levels again. These two values we put in some proprietary software, and that gives you the area under the curve, and then you can calculate the AUC by MIC ratio. Now, the trough levels which were used previously were advised to be used once the antibiotic has achieved a steady state. So the first 2 or 3 doses will be empirical, and then we will do the drug level monitoring. Usually after 4 doses have been given, a steady state is reached. But in patients who have renal failure and are on hemodialysis, we check the pre-dialysis trough levels and then decide on the administration of the antibiotic. We need to be clear that around 30 to 40% of the drug gets cleared by dialysis. So the drug dosages, whether given during or pre-dialysis or post-dialysis, will differ by this much amount. The usual starting dose is 15 to 20 milligrams per kg body weight, given every 8 to 12 hours. And in serious infections, we may consider a loading dose of 15 to 30 milligram per kg. The maximum we go to a 3000 milligram. What about the resistance to vancomycin? So we have vancomycin intermediate Staphylococcus aureus and vancomycin resistant Staphylococcus aureus, but luckily the resistance in Staphylococcus is not so prevalent. What we are seeing is something called as a creeping resistance. So the MICs are rising gradually. And so there could be a time where the breakpoints are such that the Staphylococci would be considered resistant. And this is one concern. Resistance among enterococci is already a concern, and it is significant. What about toxicity? And this is a major concern why we don't want to use vancomycin. One is it's only available as an intravenous formulation, it requires therapeutic drug monitoring, and then it is nephrotoxic. It is almost exclusively cleared by the kidneys and has been shown to have significant nephrotoxicity. There is also ototoxicity associated, although it is believed it was more due to the impurities with the previous vancomycins which was being used, but with purer forms now, this is less common. What about the use of oral vancomycin? This is for Clostridium difficile associated diarrhea If the patient is stable, then the dosage is generally 125 milligram 4 times a day. And if the patient is sick, then or critically ill, then the dose is 500 milligram 4 times a day. For more severe C. difficile infection, the dose is 4 times more. The duration of therapy is generally for 10 to 14 days. What are the alternatives that we have for vancomycin? One is teicoplanin, same class as well, came around 20 years later, and some people believe it is less nephrotoxic. And with teicoplanin also, it is advised that you do therapeutic drug level monitoring. Daptomycin, trimethoprim sulfamethoxazole, doxycycline, levonorifloxacin, clindamycin, ceftaroline, televancin, oritavancin, also tigecycline. All of them have MRSA activity and can be used in the presence of MRSA infection. Where do we place vancomycin in day-to-day therapy? It's a first line in all serious MRSA infections. So there it's the antibiotic of choice. Then for enterococci, which has extensive drug resistance, vancomycin is a choice. In Clostridium difficile, including in fulminant disease, vancomycin is used. In fact, in fulminant disease, only vancomycin is advocated. And as I told, it will be in higher dosages, 500 milligrams 6 hourly. Fidaxomicin is an alternative to vancomycin, and the benefit is that the recurrence rate with C. difficile is less when we use fidaxomicin. So those who have recurrent C. difficile infection or those who are predisposed to have more recurrence, in them fidaxomicin is a better alternative. So vancomycin in clinical practice we would reserve mainly for MRSA, drug-resistant enterococci, and for C. difficile treatment.